We have a fun-filled morning. We have infectious burn patients starting off. Then we have Dr. Houston giving a transplant ID lecture. And then after that, this morning, we will have myself doing about another hour on post-exposure prophylaxis. And then we'll have Joanne Shea from TGH and then Leonard from USF talking about the specifics of post-exposure prophylaxis and how it applies. And I will probably at that time also rely on our senior fellows to try to figure out how the VA and Moffitt post-exposure issues apply as well, since they've experienced it for a year as well. So that's our itinerary for this morning. When we do these introductory lecture series, we want to go through stuff that you're never going to go through all of ID. Even if you go to a board review course, you're never going through all of ID. I think some of the purpose of doing some of these lectures is seeing things that, and talking about things that you've never seen before, or have seen very frequently. You know, how many of you guys have actually been into the burn unit and seen a patient and taken care of them? It's very difficult. If you go to many parts of the country, burn units many of them are closed, meaning they're really taken care of by usually the plastic surgeon and a critical care team, and that's pretty much what it is in most places in the U.S., including here to some degree. Although we are involved in quite a few cases as well. In fact, I believe the order sets have us involved automatically if there's a 30% or higher total body surface area burn in the unit that comes in. And that's a relatively magic number because infection rates go significantly higher when you have more than that area involved. So at least I wanted to get this whole lecture just to get you acclimated, at least the first part, to get you acclimated to how you think in the burn patient. Sort of like, you think differently when you go to different places. You go to Moffitt, it's a different thought process of how you take care of a neutropenic or cancer patient. It's a different thought process of how you take care of burn. And the last third or last quarter of the lecture is basically how you take care of burn as well, but it goes over more nosocomial ICU stuff in a rapid fire type situation. Mandel's, a combination of injury-associated immune suppression and the large area of non-viable tissue in the patient with more than 30% body surface area burns inevitably leads to infection. So the burn, and we'll talk about it, burns actually immune suppress the individual. The burns are hypercatabolic, and the burns also destroy mechanisms of our own immune system. And if you have 30% or more body surface area involvement, infection is quite common. Significance of burns: many seek treatment. 2.5 million per year seek treatment for hereditary burns, whether it be, whether it be chemical burns, thermal burns, firework burns, house fires, motor vehicle accidents, etc. A lot of people. 100,000 are hospitalized. Significant amount die. 12,000 deaths per year from burns, and many of the burns, the majority of the burns, are infection is correlated to mortality. And burn mortality is still high despite advances that have occurred over the years. Three biggest factor when it burns, and in fact, you could say in your chief complaint or when you present to me in the burn ID consult, that first sentence can give me a prognostic sign. You have a 67-year-old person who was in a motor vehicle accident, had a 25% burn, and no inhalational injury. That already gives me a mindset of where the prognosis is, because the three factors that give you the biggest prognosis is the age of the patient, the size and depth of the burns, and when you talk about percent burns, you're talking second and third degree burns, and whether there's an inhalational injury or not. Those three factors right there gives you the best prognostic factors in that individual hitting the door. And it actually holds pretty true for the most part. Obviously, there's a spectrum in there, and a lot of things can go right or wrong for an individual burn patient. But those three factors are the key factors. Three causes of death. Infection leads the list, especially in those high-degree burns, but you have multisystem organ failure, ARDS, in a significant number of these individuals, and cardiopulmonary failure as well. Well, quickly through the classification of burns by depth, essentially. If you're involving the epidermis only, the first degree burn, essentially, that's what the picture describes. It's basically a sunburn like burn. You don't have any softening off. you just have an area erythema. It's very painful. You have those cutaneous nerves right there at the ending of the epidermis that are tingled, stimulated to cause pain. There's no blistering, and it's basically like a mild to significant sunburn. What happens with a sunburn? You let it, it heals usually by itself, 4 to 6 days. No scarring, and really no treatment except for analgesia, whether it be topical or systemic analgesia, but usually it's topical. These do not, you don't count this in the surface area involvement when they count surface area involvement. Secondary burns are kind of, involve the epidermis and part of the dermis. And then if you're involving the superficial part of the dermis, and you have a superficial second-degree burn, it's usually blistering effect. Blisterings occurring there at that point. It is also still painful because you've got those cutaneous nerves right there. They heal basically 1 to 2 weeks, a little bit longer than those first-degree burns. And they heal with little scar. You just re-epithelialize. Really no scar formation occurs. Now if you get deeper into the dermis, then you have a deep second-degree burn. You have less pain because you've already fried some of the receptors and some of the nerves for the pain. You do have pain because you always have some, it's not all the same layer of burn, so you have some areas that are deep and some are shallow. So you do have pain, but the pain may not be as exquisite in some areas versus the others. There's a higher scar risk. You re-epithelialize, but you also have more risk for granulation tissue and scar as a result. And when I was a fellow, there was a guy here, he worked with, he was a plastic surgeon who gave us this lecture. And scar was the plastic surgeon's enemy. So they really worried about scar formation, and they made a big point about when a scar forms, when it doesn't form. When you have a deep second-degree burn, you often require grafting and topical antimicrobial therapy, which we'll talk about a little bit more in this lecture. Here's some pictures. The top one, probably the one on the right, look like more superficial second-degree burns. The one on the left is kind of hard to tell in the hand. That has its own risks when you have to deal with the hand. There are probably some superficial areas, maybe some deeper areas. It's just hard to tell from this picture. Then you have your third-degree burn. It's basically your full thickness. You involve all your epidermis, you involve all your dermis, and you're going down to the subcutaneous tissue. You tend to have areas that are non-tender once you're in the subcutaneous tissue. Relatively non-tender. It's going to hurt, but relative to the exquisite pain you have superficially, it's less painful. The appearance tends to be a little bit more pale white, yellow. Sometimes it gives you a tanned appearance. Obviously, these areas, depending on the size, it usually needs skin grafting for coverage. The key for us, the key for a burn patient, is coverage of skin. Sort of like the key for a cancer patient after chemotherapy, from our standpoint, is to keep them going until they get reconstitution of their white cells. The key for us here is to keep them going with minimal adverse effects until they have their skin covered. So it's analogous to that. So we talked about this. 12% body surface area is the areas of second degree and third degree added together. And we all remember in medical school the rules of 9. Your head had 9% surface body area, each arm 9, each leg 18, and torso 36, 18 in front, 18 in back. And you'll see if you look at the H&P for the burn unit, they have the H&P, and they also have a chart where they thatch the areas of second degree burn and third degree burn, so you get an idea. And they'll modify that sometimes a day or two after admission because there may be more or less area involved than they realize initially. So you do an original consult, you say, oh, this is a 36% burn, and you realize later on it was a 45% burn, and you just have to make an adjustment because they re-estimated the surface area involved. So what do you do in an initial ID consult? Sometimes these are the easiest ID consults to do because they come in from far away, no family, no past medical history, they're intubated, and all you have is what you have in front of you. That many times is the consult. All you can tell me is what you said. You know the age, you know the 3 risk factors. Well, actually, sometimes you only know 2 of the 3 risk factors. You know the age, sometimes, or the estimated age, and you know the surface area involved. You may not know yet if there's an inhalational injury or not. And that's maybe all you have as far as history. Some of these are most interesting concepts. I always say there's two things about burn patients. They're either very unlucky or they're just very dumb. Stupid things that we all may have done at one time and realized, why did I even do this? You have the guy who I remember who poured gasoline in a carburetor and blew up in him. That's not a smart thing to do. But you also have a lot of suicide attempts that go through burns and they are unsuccessful, and we get them through the process very painfully. Meaning they're a type of burn, a thermal burn, electrical burn, chemical burns are types of burns. A chemical burn poses potential issues of chemical exposure and abrasion that may occur. Electrical burns, you may not know the extent of the injury until a couple hours, days later. What's there? You might have mild necrosis, and then as a result, you might be at higher risk for Clostridia infections. We don't see that many electrical burns, but it's something to think about. The circumstances of the burn. Obviously, if you're in a house fire and you're on the sofa and you have house fire because someone was smoking, you might have more of an inhalational injury. If you're in a motor vehicle accident, the car is on fire, you might have trauma involved that you have to think about. And again, this person's not speaking to you, so you have to rely on a lot of physical exam findings to help you, and many times imaging as well. So you worry about water or dirt exposure, thrown in a ditch, for example, in a motor vehicle accident. And then sometimes we don't know this up front. Substance abuse, alcoholism. We've had many meth lab burns. They went boom, and we don't realize that how much they were addicted or dependent on medications or drugs until later on, and we have to worry about potential withdrawals. We have to worry about other issues that are involved. And obviously, inhalational injury is something that if we know when we get consulted, it's actually a good thing to understand up front.
So Dr. Montero, I think they're doing a research protocol. Almost all of them are being brought to the ER or as soon as they're admitted.
There may be a research protocol, but I would tell you if they are intubated, already, most of them get bronched anyways.
Right.
Most get bronched anyways. So, and why did they get intubated?
Protection of the...
Well, many times it's protection of the airway. You have anywhere where you have singed hair, nasal hairs, you worry about edema and protection of the airway as a result of swelling that may occur sooner or after, or if it may have already happened. If you have information, it's great. So if you have things in the past medical history is important. If you have poor arterial, if you have PVD, it's important to realize that now rather than later on. You many times don't. For diabetics, you tend to have immune issues or infection issues that are more associated with diabetes. You might have increased incidence of candida colonization afterwards that you have to worry about. Obviously, underlying lung disease or tobacco use affects the critical care doc's ability to wean them off the vent or increase the risk of pneumonia. And in fact, you guys realize that this year tobacco use was actually added as far as the recommendations or reason why people should get a pneumococcal vaccine. And people who are actually, I think, younger than 50 years of age as well. TB exposure, it hasn't really happened to us, but obviously you can reactivate latent infection. And I hate to say this, but way back when people used to get HIV tests and get CD4 counts, usually HIV tests that were negative and a CD4 count that was 40. Well, if you're acutely burned with 6-degree burns, you're not going to, your T cells are going to plummet acutely, and that's why I kept telling people about getting CD4 counts if people are acutely ill. They're really not a good marker as far as estimating where a baseline HIV person would be when they come in. In a situation like this, you can say this person was HIV negative, but if we all had 65-degree burns and we all had CD4 counts when they came in the door, we will all be AIDS defined by CD4 less than 200. So you got to realize that their cell-mediated immunity is taking a huge acute hit, and it's measured by CD4 in this scenario. Renal sufficiency becomes an issue because if they come in with, let's say, rhabdo because of some reason, what do we do with our burn patients when they come in? What do the critical care guys do? And plastic guys? They have this formula that they have to hydrate, and they really hydrate. They want to get urine output of 200 mLs an hour. So they really want to hydrate, and they have this formula for doing that, which I don't understand. I'll let them do that because that's their expertise. But if you have someone who's creatinine at 3 baseline, and you have issues. And we've had scenarios where we had nephrology come in and we had to do CVH and try to balance it. It's very difficult because you have, on one hand, someone saying, you know, a pulmonologist wanting to protect the lungs, and you have the nephrologist trying to protect the kidneys. Everybody's trying to protect their own organs, you know, as far as their specialty. But there's a balancing act that you really have to go through. Obviously, allergies and tetanus prophylaxis, usually they do a pretty good job of that. The problem is, many times we just don't know until later on. Physical exam. That's another thing. The initial burn consult sometimes is very difficult. You come in, they're laying down, they're wrapped up, and all you really can do is go to the vital signs, get the vital signs, and see what they've done. And actually, as far as the vital signs, fever's almost universal. I would say 80%, 4 out of 5 probably have fever in the first 48 hours of a significant burn. That doesn't mean they're infected. That means they have a surge response, cytokine release, and fevers. They have thermal dysregulation as well. Their skin, which regulates the burns, their temperature, has been altered in some manner. Heart rate, urine output, and blood pressure actually are important. And I always put urine output in there because that's maybe your best marker, although you have to realize that we're putting in a lot. So you have to realize that we are affecting the urine output quite a bit. But that's your poor man's swan in that unit. All right? The depth, extent, and high-risk areas you need to examine pretty well. The key, though, is lines as well. All you sometimes can look at is a guy with a tube out his mouth, wrapped up everywhere. You might be able to put a stethoscope in the lungs. Maybe you hear bowel sounds if you're lucky. And otherwise, look at the line sites. Are they dressed? Is it dressable? And what I mean by that, if you have an 80% burn and all of this is affected, you might have femoral line is the only place, and their underwear is probably the only thing that's protected the last 10% that's left in their body to be burned. And that may be the only place they can put a line, but they can't put dressings on it because the surrounding skin is sloughed off, so there's no adhesive. So make a note of that, all right? But that happens relatively common in those high-degree burns. And that's a huge entry point to infection. Maybe not the first 2 days, but that subsequent week where infection can occur. And obviously, the circumstances of the burn can determine whether there's potential for fractures, intra-abdominal processes, etc. So the systemic pathophysiology, you tend to have hypovolemia, shock. That's why they give all that fluid resuscitation. That decreases your O2 delivery and ischemia. You have immune suppression, which you already talked about to some degree. You got decreased phagocytosis, decreased chemotaxis and neutrophil function during the burn. You also have depressed humoral and cellular immunity. You have a hypermetabolic state. You see how much tube feeds? Look at the tube feeds that are going in that unit when you go in that unit. They're usually triple digits. Usually about 100 cc's an hour, 100 mLs an hour, or higher. You usually see 50, 70. It's usually what we normally see on a medicine floor. They're usually going twice as high in that unit just to try to meet their metabolic needs. There's a burn conference each Monday, and in that burn conference, there's a nutritionist that goes as well to make sure that the nutritional needs of that burn patient are met. And that's one of the things that they do. Obviously, systemic inflammatory response syndrome is occurring at the same time. Infections usually originate at sites of mucosal damage, ciliary dysfunction, and skin damage. So, and then you can get a lung or burn wound infection as well. So, usually it's whatever's been colonizing the patient is usually the thing that's going to cause the infection because, the lines are going right through them. The fluid is going in that area, and then you have the burns that's being colonized with whatever the patient's being colonized as well. The burn tissue itself, most of the time it's deep enough, second, third degree, they're relatively avascular, so as a result you have decreased phagocytosis, and antibodies go to the bloodstream in general to get there. Well, if it's relatively avascular, you're going to have an area where it's not being penetrated well enough. You have an S-guard, the thick proteinaceous material that's dry, the scab, for lack of a better word, that's overlying many of these areas, It's protein-rich culture media. It's basically a hardened petri dish waiting to be colonized and potentially penetrated by bacteria. Later on over time, you can get granulation tissue 2 or 3 weeks. That can be good, that can be bad. It says that's revascularized. But as a result, it can also support bacterial proliferation, this granulation tissue. So you got to continuously look at this potential area as a possible infectious site. The lungs, we talked about it a little bit. Inhalational injury usually results in ciliary damage among other things. You get hyperproteinemia. The normal albumin in that burn unit is probably 2. Now actually you're doing pretty good if you have an albumin 2 in that burn unit and you have a 40% burn. Because it's very hypermetabolic, so you tend to have hyperproteinemia. And as a result, you start third spacing, you start getting extravasation of intravascular fluids. So you start seeing a lot of patients who look like the Michelin Man. You know, they start thin and they start third spacing a lot of their fluids. That as a result puts fluids in their thoracic space, whether it be pleural or intraparenchymal in the lungs. You also have potentially, in certain situations, foreign parts of combustions in the airways. That's part of the reason they also do bronchoscopies to see if there's anything there that they can scoop out, for lack of a better word. Then large burns, you get post-injury hyperventilation. Think about it. So you take large burns, you start getting hyperventilate, you start getting try to get rid of a lot of that metabolic acidosis that may exist there because you have tissue ischemia. As a result of that, your lung volumes you tend to have a high tachypnea, high respiratory rate, but you tend to have smaller tidal volumes. As a result, you get atelectasis, and there's your one other risk for getting pneumonia for a different reason, because of those small tidal volumes and atelectasis that exist. Inhalational injury is basically airway or pulmonary parenchymal damage. Usually, the scenario you think about is being burned in confined quarters, although it can happen in other scenarios. If you have facial burns, if you have singed nasal hills, it suggests that really you confirm best by bronchoscopy. And even then, I would say it's suggestive of inhalational injury or not. We always say it has inhalational injury or not. I don't think we can actually say pathophysiologically for certain until post-mortem or otherwise, but you can pretty much suspect it via bronchoscopy. And most of these people need intubation because the airways start swelling up as you fluid just resuscitate them, and as the injury starts releasing those cytokines locally. And there's other components of inhalational injury. I haven't mentioned carbon monoxide, but that's the other issue that sometimes has to be brought up in certain people who have been burned in certain situations. There's the upper airway swelling that we talked about, and acute respiratory failure. So sometimes it's not just one bronchoscopy, but they do serial bronchoscopies in some of these individuals. And then it's more, sometimes there's diagnostic reasons, sometimes there's therapeutic reasons for doing this. You had mucus plugging, the atelectasis can get significant. There's been studies showing how important inhalational injury. One study showed that mortality of 56% with inhalational injury with the same skin percentage versus 4% in those who had the same skin percentage but did not have inhalational injury. It is significant. This is an old study, but there is a dramatic one, but there is a significant increase in mortality. Pneumonia is a major cause of death in these patients. It really is. Whether they nosocomial pneumonia, whether it's aspiration. Remember, you're going to 2 feet to 110 cc's an hour. That's a lot of fluid going in your belly. And if their transit time in their gut to your intestines is not keeping up, it's going to be upchucked. So you got to be careful. Realize these people are getting morphine for dressing changes, that you may be slowing it down just to keep them comfortable. So those are something that at times we have to weigh one with the other and realize how much metabolic needs can we meet without increasing the risk for aspiration pneumonia, and is this guy developing an ileus or not? And then we have competing issues to be dealing with. Now obviously ARDS from the initial insult can occur as well. We've all seen that in some of our severely burned patients. The initial wound care, usually they clean with antimicrobial detergent, soap and water, basically. It's to remove basically the dead tissue that's superficial. That's not going to do them any good there. It's just provide more petri material for bacteria that's colonizing their body. And then the topical antibiotics, which we don't know too much about, and that's why I do some of this lecture, because we don't prescribe them that much. They use them a lot to prevent infection and sometimes, in certain circumstances, treat burn wound infections. And they cover with the closed dressings because you want to prevent desiccation. In circumferential burns around the extremities, you got to worry about compartment syndromes. And actually, you also got to worry about compartment syndrome even in the thorax. So if you have circumferential thoracic, you may have to worry about abdominal compartment syndrome, lower extremity compartment syndrome, upper extremity compartment syndrome in a proper setting. So you have to sometimes get the trauma surgeon involved to see, do we need an escherotomy or not? And we don't do that necessarily so much as the plastic surgeons do in consultation with maybe the trauma surgeons, depending on the situation again. Wound care, dressing changes in our unit usually are in the morning. Sometimes I think they do them twice a day in our unit. There's some places that I've gone to where daily dressing changes, but we do them twice a day, mostly in our unit. When they get to see some of these wounds, you basically have to start rounds. Well, you start between 9 and 11 if they do their dressing changes in our unit for the most part. The time I go there, because when I'm on service, is I usually I have conference there at 11, and when they do their dressing changes on Mondays, that's when they keep them out a little longer because they take pictures of the wounds. So that's my opportunity to look at how the wounds look. So Mondays, I'll start seeing a few people downstairs, and when 9 o'clock hits, I usually go up to the burn unit and start looking at some of the wounds. It's important that we don't get the opportunity to see them every day. It's important at least we see them once or twice a week, the wound themselves. If not, you'll hear me all the time asking the nurse, how do the wounds look? They've done the dressing change at least once, and they'll tell you. And they're very good at pretty much describing the characterization of that wound. And I think it's important for us to at least get a peek at them. They do mechanical cleansing and debridement. Topical antibiotics therapy, basically what topical antibiotic therapy tries to do is prevent a partial thickness wound go to a full thickness wound due to infection. Try to prevent that from happening. We already talked about closed dressings. It's bulky gauze. A lot of times, the amount of Silvadene and gauze used in that unit is impressive. It prevents desiccation as one of its reasons as well. Some of the topical therapies, I'll talk about 3 of them. This is the one we don't use. Well, if we do use it, it's very infrequently used in our unit. Silver nitrate, 0.5% silver nitrate. It's a broad spectrum agent. It's ideal for wounds prior to wound colonization. I say that, it means it doesn't treat infection. It doesn't even treat colonization that well. It prevents wound colonization. It's difficult to use is the other thing is. You need to use continuous occlusive dressings, and that impedes physical therapy, which is another member that's very active in that unit. They have specialized physical therapists in there. Stains everything black. That's the other thing. Anything it touches to it stains black, and it's a messy thing to use. So the patient environment gets this silvery black color to it. It can leach electrolytes from the wound, and it really doesn't penetrate the eschar, so it doesn't penetrate the scab. So you see, it's more of a preventer of colonization. Not used frequently.
Do they use that as a gauze impregnated layer?
Now they have other products that have silver in them, and they have a silver impregnated gauze that they use, and there's companies all the time making different varieties of these occlusive dressings with silver or other chemicals to try to help with, covering the wound, because covering the wound is key.
And then not to staining there.
And maybe potentially minimizing staining and still having some effect. Every time I turn around, there's another agent being tested. But they all have the same motive. Yeah, silver covering and making sure that they prevent desiccation and prevent colonization or decrease colonization. This is used by the bucketfuls. I mean, yeah, they have a Crisco can of these things sometimes. It's amazing. Silverdene, silver sulfadiazine. So they use it a lot. It's a bacteriostatic agent. It's broad spectrum. It has probably better gram-positive coverage, but it has some gram-negative coverage. A little bit of fungal coverage, not much, but a little bit. Less pseudomonal coverage, less enterobacter coverage. So it's better gram-positive, slightly a little bit of fungal action, and it actually, and the material also has healing properties as well. Now, the plastic surgeons try to tell me about this, and it's hard to explain, but it has the antibacterial properties, but it has some physical components that helps with wound healing as well. It has poor, but it has poor eschar penetration, so it's best used in prophylaxis of small burns. And what it's used for, again, is to diminish the colonization that exists. Because what it exists, decrease the colony counts you have on the skin, so to diminish the possibility of having a colonized wound to be an infected wound. About 35% of the time you see leukopenia. It's amazing. You do a consult, 40% burn comes in. 21 white count, day 2, white count 5, day 3, white count 2. Almost always it's due to the Silvadine. Not always, but almost always it's due to the Silvadine. And sometimes they'll modify their topical therapy because of this. They'll do some sulfamylan, or they'll use less Silvadine. You'll see them write something after that occurs. So it's usually seen pretty quickly. It's amazing. It's not like something you see a week later. It's something that you see a few days later. They always say avoid and those who are allergic to sulfa. I'm not. Many of these people, they come in. We don't know what their allergies are.
They use it.
And they use it. I have not seen a problem with it. Have you guys ever seen a problem with it? So you're supposed to avoid it, but I think you could probably get away with it. Obviously, if they're allergic to sulfa, you're not going to use it if you know it. But I will tell you, most of these people, you don't get that history up front. You know that. Then this thing called sulfamylan. It's 11.1% methionine acetate. This is also bacteriostatic. This broad spectrum, and this one has a little bit of gram-positive coverage, but less. It's got better pseudomonas coverage and better gram-negative coverage. We use this less. You say, why would you use this less? It seems like pretty good agents. It is. And it penetrates the eschar. So this has the potential of treating wound infection, and it's used for that. It's used for 2 reasons. It's used in cartilaginous areas because that's one area where you're relatively avascular. You need all the help you can get as far as prevention of infection. So you'll see them using the knuckles, you'll see them using the nose, in facial wounds, and the ears, sulfamylan. And it's used sometimes when you have a burn wound infection, when the wound itself is significantly infected and they need help with that infection. So they'll put sulfamylan on there. Problem with it, it penetrates the eschar. It also causes a significant amount of pain. So it's more uncomfortable of an agent because it causes some discomfort. So again, it's used to prevent infection tonsillitis, like the ears, like I said. It also induces a metabolic acidosis. It's a carbonic anhydrase inhibitor. So as a result, you're actually worsening your potential post-burn hyperventilation, increasing your respiratory rate, small tidal volumes, increasing your risk for pneumonia in the future as well. Even more so with this. So some downsides and some plus sides with this agent. And I would say it is used in our unit, but it's used significantly less than Silvadine is. I'll quickly go through this. Surgical management. It used to be way back when they would just take care of the wounds and not take them to the OR until like a week or 2 later. Way back when, before my time too, guys. But now there's a trend of early excision and grafting. And in our units, we have scheduled OR days, basically Tuesdays and Thursdays for the burns. And if there's an emergent need, they'll do them the other days. But those are the scheduled days that are there for the plastic surgeons and their burns who are either on the floor or in the unit. The benefits of earlier surgical management is reduce the catabolic state, decrease infection risk, improve healing, have less scar formation. And I think that's the major reason I think they did it. If you get to them early, you can prevent the scarring from occurring. And that actually, aside from the physical appearance, it also improves their ability to take care of the wound significantly. Decrease the functional limitations and decrease the length of stay as well with doing earlier surgical management. So sometimes you'll get someone coming in on Monday. Very rarely you get someone coming in on Monday and you see them Tuesday after the OR. But usually within 48 to 72 hours they're in the OR getting debrided significantly. If the total body surface area is less than 30 to 40%, many times they'll do one-time skin grafting and one stage. If they have, it depends on the location and what skin's available for potential grafting. If you have a 60% burn, obviously do the math. You can't do that. you would have to do staged skin grafts, and that's where that's where the clock starts. And you start trying to prevent infection and coverage. With the largest wounds, you do stage closures, temporary cover, and there's not been an ideal option for permanent non-autologous graft. They have things such as skin banks or bioengineered products that help. Again, those are temporary until you're able to get in. Sometimes you're able to culture your own skin. They'll send it out from these weird cases. Culture your own skin. I think that takes a couple weeks for it to return. 2 weeks for it to return. So you still have to. You're still using time. You still have to buy that time in wound care and infection prevention for these individuals, so that you can replace with its own skin graft when you're able to do that, whether it's from your own bioengineered skin or because you've developed more skin that you can again skin graft. The grafts, I'm not going to do much of this. Let's go to the next slide. What they try to do is use large area burns first. They graft the flat plantar areas first, the trunks and the thighs for the most parts when you have large burns. Now, if you have anticipated mortality, because the more you cover, the better you are. However, if you anticipate the mortality to be relatively lower, that's 50%. That means you have a young person, for example. Let's say you have a teenager, and you have a teenager with a 60% burn, might have less than 50% mortality because of the age aspect of it. Okay, because of the age aspect. You might want to do the hands, feet, and face first to preserve function. Where if it's that same person with 60% or 60% burn, 60 years old with a 60% burn, you may want to do the trunk first to get the mortality aspect taken care of first. So they'll make those decisions as far as how they stage some of these graftings. Whenever you see them coming back from the OR, they've usually been transfused quite a bit. They lose a lot of blood, and they use a lot of blood products in these individuals. That's another thing that I tend to realize later on, especially young people who develop a fever maybe 6 weeks afterwards. You think maybe they got CMV from the blood products that they had, and they were young enough to never have CMV. So those things you have to realize. They get a lot of blood products in the burn OR. And again, the goal is to prevent burn infection. From our standpoint, to prevent burn infection by permanent closure of the wound ASAP. The diagnosis of infection in these people is difficult. Man, you go in there, you do the consult, they're 38.5, they're tachycardic, their blood pressure is 100 or over 60. You're like, man, these guys are already sick. I got to start antibiotics now. That's your temptation is there. That's one thing you got to hold back. At least the first 48 to 72 hours. Unless you have obvious reasons otherwise. And you usually don't. Hold that temptation. Usually what we end up doing is culturing them, not that first day either. We usually wait at least 72 hours many times to culture. And believe it or not, the burn guys don't want us to do too much culturing because they know that they're going to have fever. They know all this. The problem is we gotta help them with the diagnosis, and it's not easy. Very subtle. Typical signs may be absent. Everybody has fever. Leukocytosis is common in these individuals. So what's going to help you here? You gotta look at other things. Blood pressure helps, but may not be there. Altered mental status. Well, you're giving them slugs of morphine. They're in shock. They may be withdrawing, but there may be something that's different. That you see, you know for 2 or 3 days, and all of a sudden something's different. You can't pick it. That may be your first sign. Hypothermia may be your first sign. And ileus may be your first sign that there's something going on. The body's not transit. The GI tract is in sort of semi-shock for some reason. And is it the burn, or is it really something else that's going on? If you have something that's new tachycardia, new tachypnea, new hypotension, or all of a sudden a decrease in urine output, especially if you have a decrease in urine output and you have no reason for it. If you're seeing that there's the same amount of fluids, or if you're seeing that you're giving boluses of fluid to keep that urine output up, and it's just more, there's something going on. There's something going on. And at that point, you either do one or two things. You culture them, or you culture me and you do empiric therapy depending on the severity of it. And I don't get upset with the critical care team when they go ahead and jump the gun. But it's our job to either figure out when we stop afterwards. All right. And that's very hard. I think this is the hardest part in the burn unit, to figure out when to jump in with antibiotics. It takes experience to do it for a period of time. And when you stop, it's actually, I think it's easier. Easier for me. Harder for a lot of other people.
Dr. Montero, a lot of times when they come in, they had like an accident or something. They have open fractures, and they are already started like in ER on antibiotics. Like we see them.
Right. I mean,
and just continue.
Well, you have to continue that, but you have to say, okay, what's the reason for the antibiotics? Is that reason still there? I will tell you, unlike the neutropenic patient, unlike where you keep the antibiotics going until the neutropenic, my goal is not to continue the antibiotics until the skin is. You got to minimize that, because what you're doing is colonizing with worse and worse and worse agents. You go to a hospital that has a burn unit. The epidemiologist in that hospital will tell you that that burn unit is probably the place where the worst bugs are usually lie in that hospital. The most resistant gram-negatives, the most resistant MRSA, all the resistant, you get fungal infections as well. So that's where you get it, because you have skin out there that they're just going to invade, and you have a lot of susceptible hosts, and you got a lot of potential there. If you go to our burn unit, they have a burn. They're in isolation. They're all in isolation. You go in there, you have to gown, you have to glove, wear a mask, every patient, because it's so easy to transmit. We've had issues. I remember, several circumstances, several organisms in there that you go boom, 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 boom. It's like in a matter of 3 days, all of a sudden it goes down the unit. Right, Emily?
That's right.
It just happens. And it happens quickly. By the time you realize it, it's happened probably 3 days ago, because they're starting to get the infections that were quickly being colonized days earlier. That's interesting. So you had to make that balance of early on or not early on antibiotics, and you guys are going to feel uncomfortable initially doing that. That's something you guys have to realize. It's the thought process we go through there. Early antibiotics increase resistant organisms, so therefore we have to worry about, that's the downside. And increase fungal organisms, which you can get significant amount in that unit, both Candida and mold. More than you realize, and actually more than I realize sometimes. General concepts, sources, lungs, wounds, lines, Foley's. Those are common sources. And actually, we do line rates for infection control in the hospital. The highest line rates that the NHSN, the standardized, is always in the burn unit. It really is. So you do the burn units and all around the country. The highest baseline rates for all of them, it's always in the burn unit because of this. So those are your sources that you look at. And believe it or not, I think this is probably the least common, because we do the best job with that. We have good nursing care, we do a lot of topical therapy, and we look at them at least the nursing staff looks at them every day. They're really on top of this. So most of the time, it is not the wound in our unit that's causing the problem. Most of the time. Not all the time. Most of the time. I think the line is number 1. Lungs probably number 2. Urine is probably number 3. And maybe 2 and 3 can flip-flop every now and then. And then you have others. And then you have a whole host of other things. Like, they're basically an ICU patient at that point. The pathogens, multiple resistant gram-negatives, or multiple resistant Acinetobacters, you go around the burn group, they have their meetings. All burn units have had this pathogen in there. And in this hospital, or TGH, that's been the place that we've had the worst problems in with multiple resistant Acinetobacters when we've had the problem. And that's the same thing in all the hospitals that have burn units. They've really had problems with MRSA, yeast, fungi, herpes. Don't forget herpes as well. If you start seeing redness in some people, especially around the lips, crustiness, don't think it's bacterial. You can reactivate HSV. Now, is that going to kill the person? No, but it's going to make things worse and can potentially slow down healing and progression in that patient. Burn wound sepsis is decreasing because there are effective topical agents, early excision and grafting, our use of biologic temporary dressings, and infection control measures. And I think over time we've gotten better in our general ICU care. I put this in first, although it doesn't apply to most of our burns. let's say a typical burn sometimes. If you think about 2 organisms, and Senate will ask you this question, 2 organisms you worry about that if you saw the patient 2 hours ago and you staff it with the attending 2 hours later, and the cellulitis has gone from here to here, group A strep and Clostridium perfringens. Those are the 2 organisms you really worry about. Group A strep probably being the more common one out there that causes that, so that should be the top of your list. So in burn wound sepsis, group A strep is one of the things that we really worry about. And in years past, decades past, we used to actually start them on IV penicillin. I remember the days we did IV penicillin in our burn patients instead of nothing. Reasoning was to prevent the group A strep. I think they probably underestimated our ability of topical antibiotics and our wound care to do that, so we don't do that anymore. But we used to do that way back when because of the fear of group A strep. Staph aureus, it's called less aggressive. Can you believe it? We actually said that. Less aggressive than group A strep because group A strep is much more quick. And Clostridia species can really cause burn wound sepsis quickly. Then, just like any patient coming into the hospital, you get colonized. When you get colonized with usually gram-negatives, and MRSA is pretty quickly in the burn unit. But you can, with gram-negatives as well, just like any other patient coming into the ICU. Lower colony counts, typically in the burn tissue, than the gram-positive, but do exist. And by week 2, if untreated, the counts are not that high. It can penetrate the eschar to prevent to non-viable tissue. They proliferate, and what can happen if you start seeing a scab or eschar just lifting up? That's not a good thing. That usually means there's infection underneath there. If it's just lifting up and there's some creamy stuff underneath there, that's a problem. It's a real problem. And if you have unburned tissue that's invaded, you can get systemic spread as a result of that. Just put a slide in that. Don't forget that you can get fungal wounds infections in the burn unit. Like I said, we tend to underestimate this sometimes because we're all worried about our multi-drug resistant gram-negatives or MRSAs or other relatively resistant gram-negatives that we see in the burn unit. People have seen a lot of fungal infections with sometimes relatively unusual organisms. Alternaria, mucor, rhizopus infections that have occurred in our burn unit. We've had one unusual infection that's not even listed here, atypical mycobacterial infection that we had last year as well, that you can get, and you can have some of the burn tissue being penetrated by these unusual organisms that you have to be thoughtful of. Now they don't come in with this. This is usually a patient that's been in the unit for 2 weeks or longer, and they've taken care of their bacterial pathogens, but you have to realize what's next when you're taking care of the bacterial pathogens. We used to do this. We don't do this anymore. When they do tissue cultures, I don't think I've seen one in a while. When they used to do tissue cultures, they used to send for a path and they get a colony count of how many organs they saw in gram stain. And if you had greater or equal to 10 to the 5th, that was considered an infected burn wound that needed treatment. And they used to do that when after the debridements, they would actually get a colony count as well, or they would just do it for diagnostic purposes. They don't do that so much anymore. And this is a chart I saw somewhere, and I just pretty much stole it and put it on the slide. As far as one burn unit does for prophylaxis and treatment of burn wound infections. So they think about it. You have a clean burn wound, no problems. So what do you want to do there? You want to prevent that colonization to become infection. So what they tend to do, either silver nitrate, that prevents colonization, which we don't use that much. We use boatloads of silverine, and that's what they would do. No systemic therapy is needed, and everybody gets this. A lot of these people get excision and debridement. If you have superficial infection or colonization, pretty much at that point, to prevent infection, you would do silverine. If you already have infections or if you have cartilaginous areas, that's where the sulfamyline goes in. Again, it's a local area. You don't need IV antibiotics at that point, but you need debridement. If you have gram-negative invasion, remember, what's our best topical gram-negative organism? Sulfamyline. So they would use sulfamyline here, realizing the drawbacks of sulfamyline that we've talked about earlier. You may need infection, if it's deep, you may need excision. You may or may not, I have to put a plus minus here, need systemic antimicrobial therapy there. If you have gram-positive agent and suppurative, or non-suppurative, you use sulfamide there. If it's suppurative, you also will need systemic therapy. Also, we need to be either unroofed or debrided further as well. Obviously, if you're not going to leave a burn wound that's pus-like without debridement. And then they ended up using topical nystatin. I actually don't know if we have topical nystatin that we use that much in our units for the superficial or invasive fungal infections. And then, depending on if it's invasive or not, whether we use systemic therapy or not. So topical is a decent chart of what a thought process as far as topical therapy and why, and realizing that sulfamide is more a gram-negative drug and more invasive. Sulfamide is more of a drug to prevent infection, not to treat infection, and better gram-positive agent. We talked about pneumonia, most common infectious complication, risk to corp. We've already talked about. And then the rest of the talk is going to end up being a little bit more of an ICU type talk, because all these things can occur in the ICU, and all these things can occur in our burn patients. So thrombophlebitis can occur. It occurs 5% of burns greater than 20%. And then burn patients, like other, if you already have local signs present or symptoms present, you may only realize that you have it when you have bacteremia, and more bacteremia, and more bacteremia, and more bacteremia. And the problem is, many times you have central lines, and you're not going to be able to see the signs and symptoms that are present. And if you have sepsis no source, persistent bacteria, you tend to have a high mortality in our burn unit. I have not seen venotomy used in excision used in our burn unit, but I've seen it used once or twice on our other ICU patients in the past. This is the one place we still do this. It used to be 10, 15 years ago, we used to change lines routinely, change central lines. That came out of vogue. The one place we still do it is in the burn unit. And the reason is it's a colonization issue. They're heavily colonized. And again, you'll see that in our heavily burned patients with strategically placed burns, we may not be able to address these lines very effectively. Infective endocarditis, very infrequent. The reason I put this is I remember one case of infective endocarditis from a burn patient. We think about it a lot because we have a significant amount of people get Staph aureus bacteremia, and sometimes that persists a little bit longer. But it's relatively uncommon, and something that we still should consider. Other infections you think in the ICU setting in general, sinusitis, especially people who have nasal tubes in, NG tube in, or nasally intubated if they needed to be nasally intubated. Obviously, with the heavy focus recently, infection prevention and UTIs, Foley's. I mean, it's a very common scenario on the floor, in the unit, in long-term care, nursing homes. It's an issue here. Actually, sometimes it occurs, I've seen in a few cases, is parotitis. Not only in the burn unit, but you got to think about it elsewhere. You have people in relatively dehydrated states have little bitty stones in their ducts, and they can get significant parotitis with significant induration. That's gotten pretty severe in certain individuals. You usually get ANT involved, so you usually get the lemon and all that stuff going so they can milk the, or actually get the juices flowing, so to speak, out of those ducts. Suppurative chondritis is, we see infrequently, but that's what the sulfamide is there for. We put on the nose and the ears and the cartilaginous surfaces to prevent suppurative chondritis from occurring. Other infections you see, you get acalculous cholecystitis, common in burn units, common in actually regular ICUs as well. I think we underestimate this sometimes. Intestinal ischemia can occur in many of our units. I think we resuscitate pretty well in our burn unit. We don't see this as often as I would have thought we'd seen. But it's something you got to consider if you have an issue with abdominal pain, ileus, worsening ileus, let's say a week after they come in. Ischemia is a possibility, especially on older patients who might have more compromised vasculature. CF colitis is something, to be honest with you, has not been a huge issue ever that I can think of in our burn unit, but it's something we think about a lot in our other ICUs. Anybody who has a rapid jump in a white cell count to over 25,000, it's gotta be, you gotta think in your mind of C. difficile is in the differential diagnosis. I don't care what else is going on. Especially if they have an ileus, or especially if you have diarrhea. But most of those people are on 2 feet, so you have issues to distinguish there. But a good old-fashioned nurse can tell you by the odor of it whether they suspect it or not. And by golly, sometimes that's actually better than your C. diff toxin. And then we mentioned abdominal compartment syndrome in the past. You get oliguria, metabolic acidosis, and you can develop hypoxia and increased airway pressures. So they had these. I guess they still have these Foley catheters that can measure pressures sometimes to help. It's not a perfect test, but help diagnose a possible abdominal compartment syndrome. Other infections, toxic shock can occur when you get hemodynamic instability out of proportion. When we think of toxic shock, we think group A strep, Staph aureus as well. Herpes simplex. Don't forget this agent. If you have, especially if you have facial burn, and you start seeing a little bit of crusting, or start seeing some black eschar, I'm not sure what that is. You can swab it if you want, but it's painful to swallow. I usually go ahead and give them an empiric therapy of acyclovir V2 many times, or if your gut's not working, I'll even give it IV. You can swab it if you want. Most of these people are going to shed it. And if you even in doubt, go ahead and give them a little short course of acyclovir. Not going to harm them that much. And then you get multisystem organ failure, you can get gut translocation of gram negatives and cytokine release. Don't forget drug fever. It does exist in the brain as well. Exists in a lot of places that we always got to think about. DVTs as well. As far as antibiotics, aside from what we used to talk with distant past we use, there's really no for prophylactic. There's really no need for prophylactic antibiotics. The only time you will see it is when they go in the OR. They'll give Ancef. They'll give Ancef. You'll see it. Ancef, I'll call the OR. But that's what they'll do. Now, if they're already on antibiotics, they just go ahead and continue the antibiotics that we're giving them. Remember, we're trying to prevent more and more resistance, and we're buying time, eventually for skin coverage. That's our goal. With antibiotic use, it's judicious use clinical judgment, and it's something you just got to get accustomed to in the burn unit.